It is great to be here, and I appreciate the invite. So I'm going to kind of tie up kind of where we started with kind of what we know and what we don't know, and talk about return to activity. My background is obviously working in the athletic area and return to sports, but we've done a lot of research in the past several years about return to school and return to learn, especially in high school athletes, with kind of a 360 looking at different medical providers as well as school support staff, and we found a lot of disconnects that are certainly of concern. When we talk about young athletes, their number one goal is to be a student, and so we really need to keep that in mind. But when we talk about return to activity, return to sport, return to work, return to duty in our military, it all encompasses a lot of these same areas. And so historically, concussion has really been treated with rest and kind of, just take a break, mental rest, physical rest, and we're really shifting away from that. And I think it's an area that's both ripe for research and important from a community member standpoint as to what we should be doing. And if we look at the basic state of the literature, when we look at who does best after a concussion, when we look at folks who kind of go back to school, go back to sports, full on right away, they tend to do worse. But those who don't do anything have the second worst outcome. So this whole situation of don't go to school, stay in a dark room, don't do any mental activity, don't text, don't be on your computer, we really need to shift away from that because that does not help our patients at all. Who does best are those who do certain school activity and light activity at home. So when I'm talking with parents, I always say, we want to get your child into school with what they can do, but it's also okay for them to sweep the kitchen floor or do light chores around the house. And that's actually going to help to facilitate their recovery. We don't want to shut them down completely. So if we look at the most recent recommendations from the International Consensus Statement, they only recommend a very brief period of physical and cognitive rest, about 24 to 48 hours. And after that, we want to actively engage our patients depending on the types of symptoms that they presented, as some of the other speakers have mentioned. Our rehabilitation needs to include both cognitive and school activities. We want to try to integrate them back into their social environment as best we can to reduce anxiety and some other things that can happen if we try to isolate our patients. When we talk about returning to sport, we want to make sure that we do the brief period of rest. We have some symptom-limited activity, which is really going to differ patient by patient. And then we want to get them fully returned to school before we consider returning them to sports. So we need to address academics within our treatment paradigms. And so when we talk about post-injury concussion management, I like to equate it to orthopedics and what we would do with an ACL injury or an ankle sprain, because it is somewhat similar in that we have this acute stage where we're going to remove them, we're going to look for our immediate referrals of an injury that's more serious than a concussion. But then we get into this deficit management or this subacute phase where we want to begin some active treatments. We want to make sure that we're doing things to engage them both physically and mentally, but not make their symptoms worse. And then we can think about returning to activity, fully return to school, and fully return to sports. So the whole premise for treatment is to really not shut them down completely. If we think about an athlete who has a hamstring injury, we don't just sit them down and don't do anything with them. We'll do stretching, we'll do exercises with them to engage the hamstring as much as we can without making the injury worse. So if your patient can tolerate light aerobic activity, they can walk across campus, they can ride their bike, they can do things like that, that's okay. If they can read without increasing symptoms, that's okay. That'll actually probably be beneficial in that they won't feel that they're falling behind in school. So we really need to think about what they can and can't do with their symptoms. And we know that exercise is good for a lot of different things, including brain injury. From a physical standpoint, with athletes who are worried about losing their spot, losing their fitness level, same with the military, we want to make sure that they can be engaged in some type of activity. Psychologically, this is probably where these early interventions are most beneficial because we're not isolating them, we're allowing them to be involved to some degree. If you've ever been around high school and collegiate athletes, the worst thing you can say to them is, you're not doing anything. You can't work out, you can't practice. They want to be engaged. That's their life and that's their identity. And there's a lot of, obviously, psychological and mental benefits of exercise as well. So we need to think about treatment in this context that's a little bit different from return to play. I think historically we kind of went, you have a concussion, when your symptoms are gone, we're going to start this return to play progression. And there was no middle ground. And that's really where we're focused right now. And so as far as treatment, there are early studies that have found a lot of positive findings with various types of treatment for concussion, including cognitive rehab, vestibular rehab, vision training, and even light aerobic exercise, where we have people just working, riding a stationary bike or on a treadmill. For some of the different kind of trajectories of concussion that have been described today, physical therapy, manual therapy is also important. Now, this can be even more so with our folks that are having persistent or prolonged symptoms. And one of the, I think, interesting things that came out of the most recent guidelines was really, what is recovery and what should be expected recovery? For the long time, there was this, concussion should recover in 7 to 10 days. And that was based off of a 2003 NCAA study that looked specifically at collegiate athletes. We know that our population of concussed individuals is much broader. And so the recommendations today are that a normal recovery is about 10 to 14 days in adults and can be up to 3 to 4 weeks in children and adolescents. So as community members, as providers, it's important to make people aware that you could have symptoms that might last 3 weeks, 4 weeks, and that's normal. But if you follow these treatment plans, if you see your healthcare provider, there's a very good chance that you're going to get better. And I think that's the other important message. A lot of times we hear about some of these issues with CTE and other problems down the road, but that's a very small subset of individuals, and most people do get better, and that's an important message that we need to deliver as well. So when we talk about treatment, we want to know, can we predict outcomes, and can we figure out what is the best treatment? And Dr. Lifshitz initially kind of presented this, and I'm just going to go over a little bit of how we might do this. We can look again at those risk factors, we can look at the clinical trajectories, and then figure out what is the best treatment pathway. Go ahead. And we can look at all of these different treatments. Maybe the patient just needs to regulate sleep. Maybe they have mood and anxiety issues. Maybe some exercise would be beneficial. Maybe we need to think about their diet and what they're eating. We can use academic adjustments in school, vestibular therapy, ocular motor training, and then directly looking at cervicogenic and migraine issues. And so there's a couple of different taxonomies of how we might look at some of these different trajectories, subtypes, and treatments. Go ahead. And some of the targeted treatments that we can then address, where we might be looking at patients who have vestibular issues, seeing a vestibular physical therapist, doing specific exercises and training and treatment, and these have been found to be extremely beneficial. We can even look at those with anxiety and mood disorders and ensure that they're seeing appropriate providers to target those issues. And this takes a team, and this is where concussion really doesn't belong to one specific discipline. It takes multiple groups, multiple professions in order to actually treat and manage. If the high school is fortunate enough to have an athletic trainer, they're a great conduit to all of the community referral sources. But in Arizona, we know that about 30% of our high schools do not have access to an athletic trainer, and nationwide it's at least half. And so there's a lot of kids that don't have some of that on-site health care. The coach, the teachers, the academic support staff at the school also need to be part of this process because they're going to be involved with any type of academic issues. And that really leads us to having a medical system and a school system that talks to each other. And a lot of the work that we've done, where we've interviewed principals and superintendents and teachers and medical providers, there's a lot of disconnect between the schools, between the medical providers, and I think that's one thing in Arizona with a lot of our clinics, we've really tried to bridge that gap, but nationwide it is a problem. And so we need to make sure that the school systems are prepared to manage not only concussion, but also brain injury in general in non-athlete populations, and that we have good communication back and forth. And so there's a lot of wonderful resources that really identify how do we do this and what are the best practices in getting an interdisciplinary school management team, doing training for teachers, for coaches, and others, having good assessment and monitoring protocols as heard by some of the speakers today, and then having the intervention strategies that we can use to help these students return to the classroom successfully. And so the ideal policy really should contain, what we're talking about from a description, who is involved, what is the process to help students return into school, And then when is it okay for them to both return to physical activity and full school activity? And this is the return to school strategy from the Berlin guidelines, where we start off with daily activities at home that do not give the child symptoms. This is where it's okay for them to read, okay for them to engage on the computer in something very simple, maybe not Fortnite, but something that's gonna, really just get them, to be able to, get onto Google Classroom and do an assignment. Then we want to continue to engage in school activities, return to school part-time, and return to school full-time. And we might see different academic adjustments throughout this process. Now, when we talk about the activity side, this is where, again, we've got some changes. In the past, we used to have all these grading scales and guidelines, and if they were okay in 15 minutes, they could go back in the game. But we are so far removed from that now that we're really looking at processes to safely return them. No one lets them go the same day. And so once they've gone through this subsymptom treatment and rehab, we get them into the return to activity criteria. And we shouldn't think about returning to sports until they're in school full-time without accommodations. They're asymptomatic at rest, have little symptoms with an increase in activity. And then we transition them from this treatment rehab stage into this return to play protocol. That gets them through several different stages with about 24 hours in between each stage. So they're starting off with symptom-limited activity, and then we begin to progress them. So this is a process. I like to use the analogy, if you had surgery to repair your ACL in your knee, and your orthopedic surgeon said, well, you can take the brace off today, you're not playing in a game tomorrow, right? We go through a process, and it's the same way when we think about the brain. And so we need to do this as well. And the big message is obviously the classroom in our children, adolescents, and even college-age individuals is more important than their sports. Those are my kids sparring in karate. I think my daughter usually wins. But we need to kind of take this approach where now concussion can be treated. We want to get away from cocooning people in dark rooms. We want to think of return to activity as a progression and part of the rehabilitation, get them back into school before we get them back into sports. And I think that's it. Thank you.